Kia ora tātou, everybody. Bruce Arrell's my name. I'm the director of the Goodfellow Unit, and it's my great pleasure to welcome two experienced and popular speakers. Our topic tonight is stroke, devastating but preventable. So hopefully we'll be able to prevent a few after this webinar. So we've got Professor Anna Ranta, who's a academic at Otago University on the Wellington campus. And she leads the Wellington and Central Region Stroke Services, as well as Professor Rafe Stewart, who's from Auckland University, Auckland Hospital, and private practice in the Auckland Heart Group. He's honorary professor at the University of Auckland and chair of the National Cardiac Clinical Network. So welcome, folks, and we'll hand over to you.
Kia ora koutou katoa. No te amana o ka tupuna, no te amana aho, ko Elbe te awa, ko kaukau te monga, ko Anna Ranta tako ingwa. No reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you everybody for joining us today. So we'll be talking about stroke, devastating but preventable, and it's a bit of a tag team effort with me getting started, and then Rafe will take over once I'm done, and then we're trying to leave lots of time for questions at the end. So just a bit of an overview. I'll be talking very briefly about the devastating part, because I presume most of us are pretty familiar with that, and I'll be speaking mostly about the preventable part, and I've kind of lumped primary and secondary prevention together, and I'll talk a little bit about TIA at the end. So stroke, a bit about stroke incidence, outcomes, and inequity. So stroke is the second most common cause of death and disability globally. And stroke volumes are due to rise in New Zealand by 40% between 2018 and 2028. That's a bit of some work we did for the Ministry of Health a few years ago. And the mortality is quite high, 20 to 25%. And what's also pretty concerning is we're seeing a rise in people with stroke under the age of 25, currently about 20 to 25%. We've recently done a very large countrywide study looking at Māori and Pacific and rural patients. And we've known for a while from the ARCA studies that Māori and Pacific Islanders get strokes at a younger age and have a higher incidence. What we've more recently found is that non-Europeans are 33 to 44% less likely to be independent at 3, 6, and 12 months after they've had their stroke, even correcting for baseline differences in risk factors, age, and severity of stroke and stroke type. And especially Māori seem to be very disadvantaged, with 75% being more likely to have died by 12 months. We also see quite significant geographic inequity with non-urban patients. So these are not necessarily place of residence, but patients who are initially presenting to a non-urban hospital. With those 28 to 33% of them are being less likely of being independent at those timeframes, 3, 6, and 12 months, and 57% more likely to have died. Non-urban people also are more likely to have had a TIA prior to their stroke, suggesting that they've had less good access to TIA care that potentially could have prevented their stroke. So you will be very familiar with the variety of risk factors that are putting people at risk of stroke. And when we look at ischemic and hemorrhagic stroke separately, because they do have slightly different pathology, of course, we see there's slight difference, but there's also overlap. And this is from the Interstroke study, and they're ranked here in order of prevalence. So age is the most significant risk factor, but not something we can fix. And then hypertension is a close second. And that's really important because it is relevant to both hemorrhagic and ischemic stroke. And then atrial fibrillation is the last one. I will spend a little bit more time on those two in particular, but we'll be touching on other risk factors as well. Let's talk about hypertension. So hypertension can be treated with just about any drug from a primary prevention and secondary prevention perspective. And really primary prevention hypertension treatment is something you know more about than I do. And I'll be talking almost, very much kind of about stroke specifically. And a lot of this is also secondary prevention. So if you've had a stroke or TIA, we want the blood pressure to be less than 130. Some of the guidelines do still talk about a blood pressure under 140, and that's based on more historical data. The studies looking at a lower blood pressure are not as as strong in the stroke literature, but of course we do have the SPRINT trial, which tells us really the lower the better. And we have kind of gravitated towards trying to get below 130. It is often very difficult in patients who have stroke and have high blood pressure to get the blood pressure quite that low. We generally start with ACE inhibitors, but just about any drug is really acceptable. There's some evidence that beta blockers are not as favored as other drugs unless you have ischemic heart disease. And something that isn't really thought about very often is, but hypertension obviously is a major risk factor for atherosclerotic disease as a cause. And it's not necessarily that high of a risk for atrial fibrillation. Maybe Rafe will talk more about that, but there's often lots of comorbidity, and it's important to get the blood pressure down if you have atrial fibrillation, because it increases your bleeding risk if you're then starting anticoagulants. So that's sometimes something that people don't think about so much. We really want that normalized before you start anticoagulation. It is the most important risk factor to intervene upon if you have ICH and small vessel disease. Now let's talk about antiplatelets. And antiplatelets, we've been using them for many years, and you're very familiar with various antiplatelets. There's still not very good data for antiplatelets from a stroke perspective in primary prevention. So if a patient comes to you and says, I'm terrified of having a stroke, I haven't had a stroke or TIA, I really want an aspirin, there actually isn't very good evidence to support that practice unless they have maybe other risk factors for other diseases where that might be more indicated. A question we get a lot is what to do with patients who have white matter changes on imaging. And there isn't really great consensus about this internationally, but I and probably many of my colleagues, if we see extensive white matter disease, we might at least consider aspirin, have a conversation with the patient explaining that the evidence isn't great, but you do worry about things like vascular dementia. Now, from a secondary prevention, that's really where antiplatelets are most important. And the mainstay is aspirin or clopidogrel monotherapy. People ask me about aspirin dipridamol. We've really gravitated away from that. It's a twice-a-day dosing, and it also causes a lot of headache when you initiate the therapy, which causes problems with adherence. And some of us believe that dipridamol and aspirin just isn't quite as effective as clopidogrel. But if you look at the studies, it's not quite so clear cut, and there's still a few fans out there, but we've gravitated away from it ever since clopidogrel has become much more available. Now, there is also dual antiplatelet therapy, which is generally aspirin plus clopidogrel rather than aspirin plus dipridamol. Really, dipridamol monotherapy is not something we ever use, so we don't really consider those two as in the dual antiplatelet therapy category for particularly high-risk patients. Really, we're talking about aspirin, clopidogrel, and we treat people for 3 weeks after they've had their event. But this is only in patients with high-risk TIAs, generally using the ABCD2 score of greater than 3, having had dual events over the last week, or having a CT or MRI that actually suggests they may have had a small stroke. Minor stroke falls into that category as well, less an NIHSS stroke score of less than 4, which is a pretty minor stroke. And that's all based on the POINT and the CHANCE trials. But it's important that that's only that subgroup. So we don't use this in big strokes, and we don't use it in low-risk TIAs because it does increase bleeding risk. And you definitely want to stop it after 3 weeks. So it's very rare that we would continue it long-term. It's completely not consistent with international best practice evidence or guidelines to use long-term aspirin and clopidogrel. So you have to have a really good reason. And the reason is because it does increase bleeding risk. Now, ticagrelor has already been around in the cardiac literature, and there was a recent Thales trial that looked at this, and it's expensive. It's not actually funded for secondary stroke prevention at this stage, unless you've just had a stent placed. So we don't really use it, and the evidence isn't still as good as aspirin plus clopidogrel. The study was smaller, we don't have multiple studies, and the benefit around independence isn't nearly as good as clopidogrel and aspirin. It's really only about recurrent events. But if you've had a stent in the brain, we do sometimes use it, or we use it increasingly, and it is funded for that up to 6 to 12 weeks. And you might consider it in clopidogrel non-responders, but most of us don't really do the test. I certainly don't do. And there's some people who think we should be using it in Asians and Maori and Pacific, but really this is not really in guidelines yet. It's not something we routinely do. I'm just mentioning it to you that it's on the horizon and you might see it from time to time. Now, I'm not going to talk much about atrial fibrillation because Rafe will talk more about that, but I just want to mention that it's obviously very important. We want to treat it before you've had a stroke because AF causes the most severe strokes. And alcohol, we sometimes think of alcohol as protective in the cardiovascular and cerebral vascular space, but there's definitely evidence that alcohol increases AF, and AF is a really important risk factor. And we're starting to think less and less of alcohol as really being protective. So I think it's a behavioral change that we should increasingly consider counseling our patients at stroke risk as well. And the one other comment about atrial fibrillation is, as neurologists, we really like dabigatran over the other DOACs because that's the one we can reverse, so we can still thrombolyze. So keep that in mind when you choose a drug. A bit of a change in cholesterol. We treat everyone who's had a stroke or TIA with cholesterol unless they've had a hemorrhagic stroke, because there's some evidence that that increases bleeding risk. And if they have atrial fibrillation and no other vascular risk factors for atherosclerosis, then we might say, well, maybe not, but that usually isn't the case. But most patients will be started on a statin. And what's changed, I mean, originally the SPARKLE trial, which looked at atorvastatin 80 milligrams, so high dose, that had the best evidence. It's a pretty high number needed to treat. But more recently, a trial found that really we need to aim for LDL of less than 1.8, which was a much lower number needed to treat. And ezetimibe is something that was used in that trial as an adjunct. So that's something we need to look at using more frequently in the stroke population. Evolocumab is really expensive and it's something that's been used in high-risk patients, but it's not really available for us to use in New Zealand. What about carotid surgery? Not much has changed in the carotid surgery literature in recent years. We still really only focus on symptomatic patients with a 70 to 99% stenosis primarily. A few patients, selected cases in the 50 to 69% stenosis group we'll consider if we think there's low surgical risk. We want this done really quickly. So in TIA patients, ideally just within a couple of days, because that's when the plaque is unstable and the highest risk is for recurrence. We continue intensive medical therapy even if the carotid endarterectomy has been performed. There really isn't much role for anticoagulants in this group. Well, really none at all, unless you maybe have had a carotid dissection, and even there aspirin seems to be just as good as anticoagulants. And we don't do much carotid artery stenting. We much prefer a carotid endarterectomy. And one of the key messages really is if the patient is asymptomatic, in other words, if they have not had a recent TIA or stroke, say in the last 6 weeks, then there's very little evidence that you're doing them a favor. The stroke risk is about 1% per year, and the surgical risk is 2 to 3% a year. So, you're taking a pretty big upfront risk for a pretty low risk problem that you can treat generally quite well with medical treatment. So a few other things to consider. Obviously, there's important considerations about diabetes care, which needs to be optimized, that you probably know better than I do, but I did feel like it needed to be mentioned. Driving advice is important, 1 month for a single TIA event, 3 months for multiple events. Professional gets a little bit more complicated. And medication adherence, obviously important, and you're the experts in that, but that's one of the reasons why I don't really like aspirin plus diprotamol. It's also one of the reasons why I start statins slower and more gradual, even though the evidence is in the high dose group, but people complain about side effects, and so that's one way of addressing that. And also, please don't forget counseling people on the importance of recognizing stroke, and you all should have a FAST poster in your surgery, please, to remind people to call 111 if they have any of the symptoms depicted in FAST. Now, just finishing up really, I wanted to talk a little bit about diagnosing TIA, and some of you may have heard me talk about this. I talked a lot about TIA about 10 years ago when we had a trial, and briefly mentioned that, but the diagnostic criteria for TIA are basically you want a sudden event that's maximal with onset and then improves. It's not something that builds over time. Not even seconds, it's instantaneous, because it's a vascular event, and 1 second you have an open vessel and then you have a closed vessel, and that's how the symptom is triggered. There usually aren't stuttering symptoms. Most TIAs resolve within 30 to 60 minutes. If it's lasting hours, it's probably a stroke. And if you were to do an MRI scan, you'd probably see a lesion. We treat them similarly, but if you have a stroke, the risk of recurrence is even higher than having had a TIA. We want a focal neurologic deficit, and we want a negative symptom. So we don't want tingling, we don't want visual scotoma, we don't want limb jerking, we want numbness, we want weakness, we want vision loss. And we already talked about risk factors, and I've listed some common symptoms here on the right that we get referrals to that are not really typical for TIA. The differential diagnosis, most common thing we actually see is migraine aura. For some reason, that's not often included in some case years that are published, but that is almost certainly the most common. We see a lot of functional people presenting with TIA-like symptoms, vestibular dysfunction, seizure, delirium, and these get a little bit less common. This is from the guideline, the Australian and New Zealand stroke guideline. What should you do when you suspect a TIA? So basically all patients with a suspected TIA need to have urgent clinical assessment. And ideally this is done through a specialist clinic, and it's because specialists see these people a lot. It's a difficult diagnosis because it's just historical. So there is no test really to do to prove the diagnosis. So you kind of have to see a lot of these cases to be pretty confident. And we need to do brain imaging, which isn't really accessible to people unless they present to specialist clinics. And an ECG is easy to obtain, but this is important. Carotid imaging should happen within a couple working days, ideally the same day. And then secondary prevention should be started as early as possible. Now, diagnosing TIA can be challenging. There's a lot of mimics. As I said, there is no diagnostic test. So what do you do when you suspect a TIA? Well, the first thing is suspect a TIA. You do think about it, and most of you do that really well, but sometimes they are missed. And when you're not sure, a thing you can do is you can refer to the BPAC TIA tool. You probably have a health pathway. You can go to the BPAC electronic decision support tool. Is a little bit more sophisticated than Pathways, which is not a guideline, but either way, there's help out there. Call your local stroke service, call them on the phone at least that's what we do in Wellington, and it's quite good for us to know. We then get them rapidly into the TIA clinic. If you don't have access to a same-day TIA or same or next-day TIA clinic, then there are other things you can consider. You can refer the patient to ED. You can use an ABCD2 score to help you to decide whether it's an ED candidate. So if it's a high-risk patient, it's a little bit more important they go to ED, although in some areas around New Zealand, everyone is referred to ED. It's obviously not great resource use sending these patients to ED if they can be managed in an outpatient TIA clinic. And you can consider managing them yourself. So the BPAC tool does have that option in it, but obviously you do need to access some imaging, and then you need to have a pathway to do that. If you don't have a same-day access TIA clinic in your region, I would encourage you to contact your local hospital stroke service to discuss that, because it is something now that we really should be offering everywhere. And both under and over referral are a barrier to optimal prevention, because if you're flooding services with inappropriate referrals, it's a problem, but we also don't want you to be so worried about doing that you under refer. Just a couple pictures of the BPAC tools. It's been around now for probably 8 years. It's dropped off in use a little bit since I've run around talking about it a lot, but I would encourage you to consider it. It's still out there, and we're about to do some updates. We did do a nationwide randomized controlled trial on this involving 56 practices, about 300 patients, and we did find that it markedly improved guideline adherence. It also improved stroke and TIA at 90 days, and the most significant benefit we saw in vascular event reduction at 90 days. And this was comparing practices who had access to the tool to not having access to the tool. So even if you don't use it all the time, even if you use it only once in a while, it just provides you a little bit of education along the way. And then lastly, just a slide on health equity. So this is one of my areas of research interest, and I've been traveling around the country during my recent sabbatical, engaging with Maori health providers. And we all know there's huge issues of equity, and health literacy is an issue, poverty is a major issue, but there are significant cultural barriers that are a little bit more in our realm to do something about. Rurality is an issue, but we can advocate for services. And obviously we all face workforce challenges. And I know that that's particularly bad in the rural setting amongst GPs. So some of these things are easier to tackle than others, but we do know that if there's better whānau support for people and they're allowed to bring support people, that helps. We can be a bit more proactive in screening with ECGs and blood pressure. We can do cultural safety training. We can actively reflect on our own beliefs and our own unconscious bias and avoiding labels. We can provide education. We can advocate for policy changes. And then lastly, I mean, there's some of these things are difficult to change, but we do have some tools we can change. And some tools we can use, such like electronic decision support, which is aimed to sort of level the playing field a little bit, and we can engage in research. So in conclusion, stroke is common, very disabling, second greatest killer with high inequity. We want to prevent early. We want to try to screen important risk factors like blood pressure and atrial fibrillation. The blood pressure targets are now lower than ever, and they keep going lower in stroke as well. LDL targets are getting lower as well. We actually have a target now, 1.8. Dual antiplatelets are definitely a thing, but only for a short while and only for high-risk patients. Don't forget about behavioral changes. That's actually what's forgotten the most in our TIA clinics in the hospital. It takes a little bit more time and isn't often well documented. Try to take a little bit more time for high-risk patients if you can manage. Consider cultural safety training, and consider having a look at the BPAC decision support tool or health pathways if you're not sure. And think about doing research with people like Rafe and I to try to work together and improve prevention in the community setting. So I will stop here and hand over to Rafe, and we'll take questions at the end.
Thanks very much, Anna. And welcome everybody. I'm going to talk about stroke as a cardiologist, so it's much more simple, I guess, than Anna's perspective, but also focusing on the cause of the stroke and the underlying cardiovascular disease. And the two most important and common reasons are atrial fibrillation, and in this case, so this is on the left here, this is a transesophageal image, and you can see there's the little triangular thing there, and there's a clot within the left atrial appendage. So with atrial fibrillation, there's blood clot forms within the left atrium, particularly the left atrial auricle, because of stasis, but also underlying reasons that increase stasis beyond atrial fibrillation, but because the atrium are not contracting regularly. And then that can that thrombus can break off and cause a stroke. And note the important point here is that thrombus can be quite large, and so that can block off a large artery and cause a devastating stroke. So strokes related to atrial fibrillation are often bad for that reason. And then the other main disease process is atherosclerosis. So this is the same disease that causes coronary arteries and disease of the aorta and peripheral vascular disease, and when the disease happens in the carotids or in the intercerebral arteries, then that can cause platelet rich thrombi to form within the artery, and that can embolize, causing an ischemic stroke. And in very simple terms, the first thrombus in the left atrial appendage is a stasis thrombus, and therefore the most effective treatment is an anticoagulant. And then in the arteries, it's a platelet-rich high shear thrombus, and in broad terms, antiplatelet therapy is thought to be more effective. So with atrial fibrillation, the important thing is to diagnose it. And as Anna said, because it is such a major risk factor for the occurrence of stroke, we want to diagnose it before the stroke happens, obviously, so that you can implement the preventive treatment, which is not stopping the atrial fibrillation, because we know that doesn't necessarily stop the risk of stroke, because even intermittent atrial fibrillation can be a risk, but you can give an anticoagulant which substantially reduces the risk of thrombus forming within the atrium, which can cause the stroke. And the key point, I'm sure everybody knows, is it's, the risk is there if you've got atrial fibrillation the whole time, but it's also there if the atrial fibrillation is intermittent and there in some of the time. It's not probably quite as high, but it definitely exists. So one of the key things is if somebody, is for screening is not to assume that you've just checked for the presence of atrial fibrillation once doesn't mean it isn't there in another time, and so you need to check regularly for an irregular pulse or do a simple ECG rhythm strip. And here's 2 rhythm strips, the top showing sinus rhythm with the P waves and the regular RR intervals, and the bottom one showing atrial fibrillation. So the 2 key things on the rhythm strip are there's the baseline, node C P waves you see in a regular baseline, and then the distance between the QRS complexes is irregular. So if you measure out those distances, there's no consistency about them. So sometimes you can get misled because there's baseline interference and you can't see the P waves. So those 2 things are the usual things to make the diagnosis. And it's very important that the diagnosis, because of the big implications for treatment when you do diagnose AF, it's really important that that is recorded on an ECG rhythm strip, and that rhythm strip is saved for future reference so that you can be secure about the diagnosis. So the next question is, it's not all atrial fibrillation is associated with a high risk of stroke, and I think it really depends at a pathophysiological level what is happening in the atrium and what are the things that make it more likely that blood clot forms within the atrium. But those things are incorporated in some sort of crude clinical way in the CHA2DS2-VASc score, which I'm sure people are familiar with. These include conventional vascular risk factors, the presence of heart failure or any indication of LV dysfunction. Obviously, if you've had a stroke before, then that immediately puts you at high risk. And then age. So age is a major driver of stroke risk, which we all know, and such that after age 75, then just based on that age thing alone, with nothing else, then your risk of stroke is thought to be high enough to warrant an anticoagulant, unless there's a good reason why not. So that's the CHA2DS2-VASc score, which should be calculated on each person. I think it's relatively crude though, and we do know that other things are strong predictors of stroke risk, and the biomarkers, for example, the BNP and the troponin, which you may or may not measure for other reasons. If you find they are elevated, that indicates that that's a marker of cardiac dysfunction, and that alone that's known to be associated with a stronger risk of stroke, as well as heart failure and other cardiovascular events in the future, and I believe is an indication for anticoagulation. Now, most people with AF, we will want to get an echocardiogram to evaluate underlying structural heart disease. You really need to know, why is this person got AF, and you don't want to miss an underlying cardiac thing that needs appropriate treatment. But also getting echocardiograms is unreasonably hard at the moment, and so that need should not delay the appropriate the initiation of anticoagulant treatment. So people might say, well, and there's a lot of reluctance to use anticoagulants, particularly when we had to use warfarin. Why not use the much simpler drug, an antiplatelet therapy like aspirin? But the bottom line is it's clear that it's not as good. So antiplatelet therapy will not prevent, or is very poor at preventing thrombus formation in stasis situations such as the left atrial appendage. So this is the one trial where it clearly shows that, where they looked at the risk of stroke when they gave people who had an indication for being on anticoagulant but refused to take warfarin, either apixaban or aspirin. And the risk of stroke was about half on apixaban as it was on aspirin. And very importantly in this study, the bleeding risk was almost the same. So that's a common misconception, that somehow aspirin and antiplatelets are associated with less bleeding than anticoagulants. And I think that the difference in bleeding risk is actually quite small. Now, the other flip side of the coin is, well, what about if you've got coronary artery disease or other vascular disease, and there's an indication for an antiplatelet, what should you do if you already also have atrial fibrillation? And a number of trials have been done on this is one of them, that this shows a comparison of people who had stable coronary disease and atrial fibrillation, and they were given combination therapy with rivaroxaban plus aspirin or just rivaroxaban. The interesting thing was that the bleeding events were significantly lower if you just took the rivaroxaban. And that's what we know in every study that's done. If you take two drugs that cause bleeding in different ways, you will have a lot more bleeding. So that is the problem of adding an antiplatelet to rivaroxaban. We're very aware of that because we unfortunately do it quite often in cardiology, and people have had stents where we're very concerned about the early risk of stent thrombosis. But over the long term, almost always you're better just reverting to the anticoagulant, so the rivaroxaban alone. And in this study, actually, the ischemic events over the long term were actually lower just on the anticoagulant alone too. So if you've got atrial fibrillation and you've got stable vascular disease, you're better to use the anticoagulant rather than the antiplatelet, except under specific situations where there's a early risk of stent thrombosis, which you need to maybe discuss with a cardiologist. So one of the concerns, a very common concern, is the risk of bleeding, and actually it is true that in the trials the risk of stroke and the risk of a big bleed are kind of similar when in people who are on an anticoagulant. The key thing is there's a big difference in their long-term impact. So normally a bleed is not good in the short term, but you can recover from it, and normally people are okay. Whereas a big stroke from atrial fibrillation has a devastating consequence and it can have a devastating consequence from that time on. So normally, and the guidelines, the ESC guidelines recommend that, except if you've actually got active bleeding or a very high bleeding risk, you're better to take the anticoagulant than not. And certainly things like frailty and falls are not a reason to not be on an anticoagulant. But the key thing is you really need to make sure that we're doing things that don't unnecessarily increase the bleeding risk. And the key things, some of the key things I've listed here. So the first thing is to make sure that the anticoagulation dose is appropriate to the person. So it's based on the person's age, maybe frailty. Renal function is very important, dose reduction with reduced EGFR, and you can also dose reduce if there's a high bleeding risk. The second thing is it's amazing how common it is for people just to be left on their aspirin if they had it for some other reason, and the dual aspirin and anticoagulant significantly increases the bleeding risk. So really looking at whether the antiplatelet is still needed or could be stopped. And then, is gastric protection with a PPI, could that be used to reduce bleeding from the stomach? And other bleeding risk factors, obviously, non-steroidal anti-inflammatory drugs, alcohol, and Anna mentioned blood pressure as well, particularly important for intracranial bleeding. So this is just mentioning the two main novel anticoagulants that we have in New Zealand, the dabigatran and rivaroxaban. So I think these drugs should be preferred for most people over warfarin. Although I guess if you're on warfarin and you have stable INRs, that's okay. There is a slightly higher risk of intracranial bleeding on warfarin in the trials compared to these other novel drugs. There are some situations where it's absolutely needed to be on warfarin and specifically mechanical heart valves, where these drugs do not adequately prevent the thrombus forming. So Anna mentioned the value of the reversal agent. There's a monoclonal antibody. It's amazing stuff. It binds to the dabigatran and just stops it working and stops the bleeding straight away. It costs about $5,000 a pop though. So you certainly don't use it for minor bleeding. You just wait for the drug to wear off for most patients. Rivaroxaban has the advantage, I think, in if there's a patient when you've got low or impaired renal function with a low EGFR, because it's dual metabolized by the liver, and there are trials now showing that it is actually can actually be used down to quite lower EGFRs. So we're talking now about atherosclerotic disease, and Anna did discuss the management of this, and my management is much more simple. It's just atherosclerosis, and we know we've got a number of treatments that alter the atherosclerotic disease process. These treatments often need to be taken over a time, but they have cumulative benefits over that time. And the benefits, when we're talking about preventing stroke, you're actually also preventing the risk of coronary artery disease and death related and heart attacks related to that. You're also reducing the risk of peripheral vascular disease and complications related to that. So when we're talking about these treatments, they are treating and reducing risks related to a number of diseases and not just stroke. Anna mentioned this, lowering the LDL cholesterol down to below 1.8. I mean, some guidelines say 1.4, but the fascinating thing is that the LDL thresholds have kept on getting lower and lower, and these new drugs like alirocumab, the PCSK9 inhibitors and things that are able to reduce the LDL cholesterol to remarkably low levels, 1 millimole per litre or lower. That's been shown that if you get the LDL cholesterol down to those low levels, you can even stop the disease process and lower the events even more than if you just lower a more modest amount. And it seems to be entirely safe, with the only identified clear risk being this very small increase in intracranial bleeding, but all other vascular events are lower, and so it seems to be safe. So I think that is the future, and maybe something that's easy to be sort of a bit slack on is just let the LDL go higher. But if it doesn't make any difference to the patient in any other way, the lower the better, and that risk it's not dramatic in the short term, but it accumulates over time. And that's the way to think about atherosclerotic disease. This is a long-term disease process that can be modified by addressing a number of risk factors together. And then, so the next thing is the blood pressure, which Anna's mentioned. Antiplatelet therapy, well, it doesn't alter the disease, but it alters the blood clot when you do get the disease. And interesting, as Anna said, there's been 3 large trials for primary prevention with aspirin in people who don't have known vascular disease, and those trials show about the same risk of major bleeding as ischemic events, and overall the balance of benefits and risks is pretty neutral. So why would you give somebody that hasn't got the disease something that has a pretty neutral effect? So that's not the same as cholesterol lowering and blood pressure lowering, which every study shows that you do reduce the risk overall. And then diabetes, I think the new diabetes medications, the GLP-1 inhibitors and the sodium glucose cotransporter inhibitors, they are remarkable medications in that they've been shown to reduce cardiovascular risk, shown to reduce the risk of heart failure, shown to reduce renal disease progression in the case of SGLT2. So I think these are really important advances if you're going to give somebody a long-term treatment to improve their outcomes, and of course, lifestyle. So I've got to admit, all this is pretty complicated, and I'm sorry to be daunting, and probably much I've said is could be argued, but I've also realized that I haven't spoken about many things related to atrial fibrillation that are important, but maybe not so much directly for stroke. So there's a question of rate and rhythm control. There's the importance of other cardiac, what is the underlying cardiac disease? What are the other non-cardiac diseases that are influencing the risk? And patient perceptions and wishes. These are all important things. And juggling all this in primary care in a 5-minute appointment, I actually don't know how you do it. But we've been working, Anna, I, and a number of others have been working on an AF decision support tool, which tries to provide support, individual advice that's appropriate to the individual patient, considers a number of the various issues that I've discussed, and focuses on the treatments that are guideline recommended that would be most appropriate to the individual. So that tool is available on BPAC and can be used if you are interested. So I will stop sharing, and I'll be happy to answer questions if there are.
Yep.
Or open for
We've got quite a few questions there, which I will start off reading. Thresholds to investigate TIAs and rest home population. Anna, for you, I think.
So I'll answer that. Yes, so I think that rest home patients are not all created equal, and I think it depends on how independent they are and what their personal goals are. So if it's somebody who's relatively independent and who you think would be worse off having a stroke that isn't necessarily fatal. I mean, that's the thing you have to remember. Most, a lot of people don't die with a stroke and then they're just stuck with more disability when they already have disability. So I actually favor generally treating them as you would a non-rest home person and trying to prevent the stroke and do what you can. Only if they're hospital level care or you think that they actually would really be harmed in some way by an intervention would I not consider treatment.
So Anna, some years ago, the NICE guidelines, not the current ones, suggested a higher threshold for treatment in older people. And I've always been horrified by that. I wonder if you want to calm the audience by saying that over 80 is, as long as the person's got a reasonable quality of life, they need their blood pressure treated.
I disagree with that. I think you have to individualize it. If you look at somebody asked about blood pressure. If you get dizzy and you pass out, then you cannot lower the blood pressure. And if you don't tolerate the statin, then you cannot take it. Even though Rafe and I talked about that earlier, not everyone who says they don't tolerate it don't tolerate it. But so I think that we don't treat. We don't treat based on age, we treat on what individual people's goals are. And we have to remember that we're not preventing mortality, we're preventing disability. And when you explain it to people that way, most people would rather not be disabled, no matter how old they are.
Just to put it another way, it's okay to treat hypertension over 80, because the medical students, when I ask them back, who would you treat, 40-year-olds or 80-year-olds? And they talk about 40-year-olds. And I'm thinking, if you only got the game I play is only 5 years of blood pressure medication. Who would you treat, the 80-year-olds or the 40-year-olds? And of course, you've got to treat the 40-year-olds for 30 or 40 years to prevent the stroke, but the 80-year-olds are going to happen quickly. So I just wanted to get that across.
Treat 80-year-olds.
Treat 80-year-olds.
I think
Thank you.
Yeah.
Okay. Good.
I agree with you, Bruce. But I guess the flip side is, if you a 40-year-old having a stroke is incredibly devastating because of the impact it could have for a long time after that, and young children, all the rest of it. So I guess all strokes aren't necessarily equal in the impact that they might have on a person's life.
Fortunately, we don't have to choose if we treat the 40-year-old or
no, you don't have to choose. So I guess, but all I'm saying is that you don't have to choose, but not treating a 40-year-old, even though the risk is lower, it could be more devastating if it happens. So I guess it's complex, isn't it? Also, there's cumulative risk over time, which is.
Well, I often say to people that I'm treating your blood pressure now. This is to prevent a stroke when you're 70, just so they know it's a long game, and hopefully they will keep taking their medication for that period of time. Because there's a subset of people that you both will know about who take this for 3 months and think they've treated their blood pressure, like they take an antibiotic, Yeah. There's a question there on ECGs, Rafe. Oh no, Anna, you'd like to. Would you recommend routine ECG for hypertension if it gets really high? If yes, how high? Would you consider an ECG with a blood pressure 170/90?
I'll leave that one to Rafe.
Well, what I would say is I think that it's very important, as we've discussed, is to check routinely the pulse or the ECG rhythm to see if people have atrial fibrillation. So I think that just as every time you take the blood pressure, you almost should check, is the patient has a regular rhythm, or could it be atrial fibrillation? And if there's any question that could be atrial fibrillation, you need an ECG. So in that sense, I think an ECG could be thought of, although it doesn't need to be a full 12-lead ECG, which I understand is a demanding thing. I mean, an ECG, in the good old days, an abnormal ECG does predict adverse outcomes. And if you've got an abnormal ECG, I would say that's definitely reason to treat your hypertension if you were wondering otherwise. And it might be a clue to underlying cardiac disease. So in that sense, it's hard for me not to say an ECG shouldn't be considered, but I guess you can still make clinical decisions on treatment of that hypertension without the ECG.
We cover little tricks. I learned a nice trick when I was a fourth year med student of when you take a pulse, is tap your foot, and you can pick up the AF very quickly that way, because suddenly you find the pulse is different from your foot. But the other thing I've got in my office is the little Cardia Alive Core thing that people put their fingers on. And that's very handy, I find. I just wonder if you've got a view on that. They're about $280.
Yeah, I think those I think that's a great idea. Or those sort of simple phone devices. The Omron have one as well, where you can just see the rhythm strip bang like that. It only takes 5 seconds. The nurse could probably do it. I think those automatic ways of doing it. They're also the blood pressure. Some of the blood pressure machines will alert you if the rhythm is irregular. I think sort of ways that you don't have to sort of consciously think about it when you're checking the blood pressure or the pulse is good.
I
The
think
other thing it'll do, it'll actually put out a rhythm strip that comes out on a PDF you can email.
Yeah.
So if you're not sure, you can email it to your local Auckland Heart Group are great like that, aren't they? They'll look at ECGs for us.
I think it would be useful to consider doing the life core thing routinely on people who are older as part of your cardiovascular risk screening. I think that could be really, I mean, I don't have immediate evidence that that's great, but I think there's a lot of, we see most of the patients we have with atrial fibrillation and stroke didn't know they've had atrial fibrillation. It's likely they would have had it if somebody had checked, you know.
Yeah, so we'll see if we can put that into the chat box so people can see it. It's a live core, and the app is Cardia, I think Kardia, ALIVCOR, a live core for that. Okay, we've got lots of questions. We've done that one. How fast should you lower blood? No, sorry, they're ones that have been done. Sorry, could you repeat what you said about the decision between anticoagulation and antiplatelet therapy when there's ischemic heart disease and AF? I think it's a question for you, Ray.
Yeah, so basically, if you've got atrial fibrillation, whatever else, the primary you need to be on an anticoagulant. Now, whether you need the antiplatelet depends on well, the key thing in coronary artery disease is whether you've had a recent acute coronary syndrome or a stent placed, in which case we normally say you need an antiplatelet for at least a month until the stent has been endothelialized. And so we'd use a lower dose of the anticoagulant maybe, and one antiplatelet rather than two. And then, well, sometime after that, and there's a variation of opinion, you would drop the antiplatelet. But certainly by a year, after a year, you can definitely stop the antiplatelet for most patients.
Right, okay. So 67-year-old rhythm controlled on sotalol, echo, the normal LA size and LV function, fit and well, no other risk factors. When do you suggest anticoagulation?
Well, I guess you're placing a person who's in the grey zone. I guess it's you say you're reassured by the fact that the echo is normal, but I guess I would not be reassured by the fact that she's apparently well rhythm control on sotalol, and I've personally had the devastating thing of having a major stroke in a man who was about that age, who thought he wasn't getting atrial fibrillation. He didn't want to take the anticoagulant, and then he didn't, and then he had a massive stroke. Didn't think he had any AF at all. So I think that you're not aware of the atrial fibrillation, and when you're on sotalol, of course, it'll slow the heart rate down when she's in atrial fibrillation. So she may not be aware of it. So I wouldn't be reassured by that. But I do agree it's in a grey zone, and I guess if I was faced with that lady who said, I really don't want to take it, and I can't see why I would, the one thing, the additional information you could use is measure the BNP and troponin, and if they are both normal, then that would say that she's probably is at actually low risk of thrombus, and maybe that decision might be might be more reasonable.
Anna's just typing the answer, but I think everyone would like to know regular fasting to decrease LDL. Is that to do the test, or is that to reduce the LDL?
Oh, no, I think I started answering that. I think the question is, how often do you check do you monitor regularly fasting LDL? And I guess I would say you check it 3 monthly until you've reached your target, and then you probably can check it less frequently. But I'm interested in what about things.
Yeah, so the first thing is we don't think you need to fast for LDL now. So the drugs have much bigger effect than any fasting does. So just do the test. And I mean, I don't think I mean the most interesting thing I find about the LDL cholesterol is it's a great way of telling whether people take their medication or not. Yes. So you can see usually over time you can see the LDL's gone up. So I think repeated measurements I think are mainly for reassuring the patient that what they're doing is it's something measurable that's related to taking the medication. You can say this is excellent. It's what's you're meeting the guidelines. This will really alter the underlying disease process that's putting you at risk of blocking the arteries. And you may not feel any better by taking this medication, but it is improving the health of your arteries, and we need you to stick with it. So I think that anything that does that, including a blood test that shows the LDL is down, is a good thing.
And once it's down, it tends to stay down.
It does. I mean, when it goes up, it's basically because you stop taking the medication.
Yeah, no, it's a great one. I always say to patients, you've got a Japanese-looking cholesterol, and that's terrific.
Well, that's the other thing that's hard to, I think is an important message to patients, is that what we've learned, and we've got very strong information about this now, is that it's not, we think of cholesterol, a normal cholesterol as being X or Y, but we know that it's safe to get that LDL down to a low level, and this will stop the disease process.
So that raises a question. There's a guy in Amsterdam talking about 0 LDL. So what does LDL do?
Well, that is very interesting. That I mean, you do need some LDL, but you don't need very much. And I'm not a great expert on the arguments about this, but for example, when you are born, you have very low levels of LDL, and there are times when in China during the Cultural Revolution they had extraordinarily low levels of LDL because of the starvation, and that in its own right did not seem to cause any harm. But the most robust evidence is these new drugs that can just dramatically lower the LDL cholesterol, and they just very surprisingly do not seem to cause any ill effect.
Right. Okay. A question here. I think New Zealand guidelines. A question about starting statins for primary prevention for 5 to 10%. I think they say 15% strongly recommend medication, but 5 to 15, it's a negotiation with the patient.
Yeah, well, I gotta say I've got a somewhat different view. I mean, I think a lot of it depends on the patient and the story that you tell the patient. But if you've got a 5% risk and you're 50, then you're going to have a 15% risk or 10% risk when you're 65. And depending on the patient, they might say, well, I know my risk is going to increase over time. I'm happy to take preventive treatments. Well, I don't see any downside. I mean, I think I'm not sure what the downside of preventive treatments is. If people are willing and prepared to take it, we know it reduces their risk. And at 5% risk, I mean, for many people, they would say, well, if I can take a tablet to stop a 5% risk, I will. And other people may not choose to do that. So I think it's not, I think it's up to the person's perspective, what they're, whether they're prepared and happy to take medication and what level of risk they're willing to make an effort for.
From a World Stroke Organization perspective, I'm on the policy committee, and we're definitely advocating for more of a shift to lower risk people as well, because you can actually have a much bigger population level impact if you're preventing at an earlier time, and there are a lot more people you can target than just focusing on the really high risk patients, which is the sort of the tip of the iceberg, and then you're waiting for them to have the high risk, and they can often be too late. So there's a bit of a global movement in the stroke community to prevent earlier, more aggressively, and when the risk is actually lower.
One of the other interesting insights from that has come from when you compare the genetic studies of what your lifelong LDL cholesterol is based on your genes, as opposed to what's achieved when you start taking medication. and essentially there's a big that length of exposure to the lipids does actually affect the disease you end up with over time. So you've got a modest risk that accumulates over time, but it also there's a difference of where you end up with when you later in life. So I think I think that's another perspective. We always thought that it's just reversible. You can take the tablets and everything's back to what it would be in a year or two. And I don't think that's correct. So I think it's, it's complex discussion. I think there's a danger of over treating and treating too much, but certainly with people who have a high risk or a powerful risk factor that's obviously going to put them at high risk down a number of years down the track. I think I don't understand why you would wait, especially if the person was willing to take the medication.
Just an issue about age. You mentioned about young people having low cholesterol, and I'm always struck with teenagers' cholesterol, how low it is. So what is it? Is it just an aging phenomenon? I mean, they're eating junk food all the time, but they've got quite good cholesterol because we check it for the acne treatment.
Yeah, I don't know the answer to that, Bruce, but I do know that if you look at the trials of dietary intervention for cholesterol, the impact is actually quite small. If you look at all the studies together of interventions where they've recommended low-fat diets, the LDL cholesterol is shifted by about 0.3 millimoles per liter, whereas if you take a decent drug, you can shift it by half. So, I think
I wasn't suggesting diet. I was just
I guess I'm saying but I don't know why. But I think that's the problem with lifestyle advice is that most people can't shift their cholesterol significantly by significant lifestyle advice. So you're creating this kind of sense of failure, and you either treat the risk factor or you don't. And I'm not saying lifestyle and a healthy diet isn't important, but I think the two should be best thought of separately.
Yep. At the other end, there's a reluctance in primary care to give statins to people over the age of 80 because historically the evidence didn't go there. But the Lancet review a year or so ago, where they looked at all the drugs, actually it was beneficial in older people. I wonder if the two of you would like to give your view about 80-year-olds and statins.
Well, I use statins in 80-year-olds, and I would start a bit lower and titrate up a little bit slower because that seem to be more side effects. Although, as I mentioned earlier, how real they are is not always clear. There is sort of this issue of how much life do you have left to prevent stroke. But just like I said earlier, my view is that maintaining high quality of life with independence is important. So I would always trial it, but then would have a relatively low threshold to stop it if there are intolerable side effects or problems with polypharmacy. That'd be my approach.
There's enough hassles being 80 years old without having a stroke. Yeah.
There's no doubt that the absolute risk of stroke is very high when you're 80, and I would agree, especially in a person who's got vascular disease or had a vascular event. It depends on the person, but they'd certainly have a lot of big short-term benefit from the statin if that was appropriate to that person. But I guess that's an individual thing as to whether that is an appropriate thing in the context of the individual.
The one other thing I'll just add, sometimes you have to bargain with what drug a patient will take. And it is the drug that I'll let go of first, because from a stroke prevention perspective, the number needed to treat is definitely lower for antihypertensive and antiplatelets and anticoagulants. So I sometimes bargain that statin away if they really don't want to take a lot of drugs. But I do explain that it's really a package deal, and that's the best benefit is if you take all those drugs together.
So more questions on lipids. Do you have preferred statins?
Well, for stroke, the only evidence is actually it was atorvastatin.
Okay.
That's simple.
Okay. Does menopause have an effect on worsening lipid profiles?
I don't know.
Do you know, Rafe?
I don't know. Basically the risk goes up in women after menopause. Cardiovascular risk goes up, and we tend to treat cardiovascular risk rather than the lipids themselves, to be honest.
Yep. Interesting issue with young people with severe mental illnesses on antipsychotics. I suggested to the HDSQ, whoever they are, the health quality safety thing, that for a 25-year-old on who's got schizophrenia and is on an antipsychotic, you should add like 30 years to their risk, because we know they die 20 to 30 years earlier. Because if you do their risk, it's so low because of their age, no matter what their lipid profile is. The lipid profile might be awful. I've had people with lipid, total cholesterols of 13 to 18 on omeprazole, but if you do the CVD risk, because of their age, it just isn't high. I just wonder if you two have a view on that. How do we deal? Because it's not dealt with. I've talked to the Heart Foundation about that, about trying to have some little caveat in there. But would you suggest that with young people on antipsychotics?
Well, I just think it's so. I mean, young people with antipsychotics, they're dealing with such a devastating disease, and long-term cardiovascular risk against the other things that they're having to manage seems to be less important. I'm not saying in absolute terms that they don't have a substantially higher risk. So I just think it has to be individualized, and it's probably going to be.
But we do their CVD risk, and it's 1%. So we say, oh, forget it.
Well,
yeah, I do see that.
We're missing the boat, I think.
All I can say is we don't see a lot of young people with on antipsychotics presenting with strokes. So maybe that's something that'll happen in 20 years. I haven't come. I mean, I'm aware of the increased risk, but I'm not aware.
They lose 20 years of life, basically. It's pretty well, probably because of the smoking and a whole lot of other things, I think. Yeah. Does how much of an impact does exercise have on lipid profile?
Not very much, but that's not why you exercise. So exercise is associated with lots of favorable effects on your health, most of which can't be measured on a blood test. So I think that's another reason why you don't advise exercise to lower your blood pressure or lower your lipids. You advise it, or there's a bit of an association with HDL, but it really is not why you exercise. And I think that's very misleading if you say to people to exercise that they're going to improve those risk factors, because the impact is such a small impact that it won't be perceived by the individual. So exercise should be encouraged for its own sake and because it's good for your health, but not because it has a measurable effect on your risk factors.
Got a question there. This is a good one. For someone with a high LDL greater than 5 and a 0 calcium score, I've literally had this situation in a patient who was a doctor, actually. Would you use a statin?
Well,
Well,
that's a good question. I don't know, it's not an easy one. I mean, it's not easy. I mean, I think the fact that the calcium score is low or 0 is reassuring, but not absolutely reassuring. And we've seen patients you can have lipid-laden plaque without calcification, and that's a high risk. So it's not absolutely reassuring, which means you should probably, but if you're going to make the decision that it didn't change your mind, you shouldn't have done the calcium score. You should have just stuck on a statin.
Because the cardiologist, one of your colleagues, kept them on a statin. I thought,
yeah, well, as you say, so it's obviously tricky. Different people have different views, and I'm not sure what the answer is.
Yeah. Okay, is amiodarone, a couple of questions on amiodarone there. Thoughts on continuing anticoagulations in patients who have reverted to sinus rhythm on amiodarone? Yeah,
so this is a very important point. Once you've had atrial fibrillation and you revert to sinus rhythm, your risk of stroke has not gone away, and you need to continue the anticoagulant. Whether you continue the amiodarone or not is a judgment, but the anticoagulant in general should be continued because the risk of stroke from the atrial fibrillation coming back or being clinically silent is there, and so definitely continue the anticoagulant.
Okay, are smartwatches as good as the devices you mentioned? That was me. I think that the Apple Watch trial was a bit underwhelming, but it was in a fairly normal population. I don't know.
Yeah, the trials for screening for atrial fibrillation in general populations and whether they impact on actual stroke risk have been a little bit uncertain. There's a little bit of uncertainty around, short episodes of atrial fibrillation that you pick up. And that's the problem with the Apple Watch, because it monitors the heart rhythm the whole time. And then you'll pick up these short runs of atrial fibrillation and you won't know what to do with them. Probably short runs of atrial fibrillation, the risk is very low because there isn't time for the blood clot to form with the atrial stasis. So it's probably episodes that last a few hours that are associated with the risk, but it's certainly a little bit of an uncertain area and ongoing research.
Okay, what is the current evidence for atrial appendage occlusion procedure devices for atrial fibrillation? Probably a question for you, Rafe.
Well, Anna might also want to speak to this, but so what we know is there's been a large trial where they've done atrial appendage ligation at the time of cardiac surgery. So they did it or they didn't do it, and people had atrial fibrillation, and the patients who had it done had a substantially lower risk of stroke. So we know that if you cut the atrial appendage off and tie it off, then the risk of stroke will be reduced by doing that. Now, the atrial appendage devices are probably a little bit, for the majority of patients, they probably are not a good idea. So they're associated with some procedural risk. And the trials haven't shown that they reduce the risk of stroke. They're sort of broadly equivalent, and they haven't actually shown they reduce the risk of bleeding. Interesting, because they were also given often given anticoagulants or antiplatelet drugs anyway when they're first put in. So it's a little bit uncertain, but I think in a few people who actually have bleeding, and where you can't give any, there might be a niche area, but for most people, I think they're better just to take the anticoagulant at a reduced dose, and try to deal with the bleeding as best you can.
So I'll just say a couple of things about that, because this is something that we talk about a lot in the stroke community. And basically what Rafe said, the thing to remember that if you've had a bleed on an anticoagulant, it does not necessarily preclude you from continuing the anticoagulant, because there are other reasons and risk factors for why people have bleeds. So if they have, for example, had really high blood pressure at the time, these are things that we might be able to address. So, and it depends on the size of the bleed and the disability from the bleed. So just having had an intracerebral hemorrhage does not mean you can never take an anticoagulant again. So the first thing to do is to consider whether you can actually reinitiate the anticoagulant and when, and counsel the patient about the risks of that. And then we can sometimes drop the dose, but we don't absolutely have to drop the dose. So this is all very individualized. So this is something you want to do in connection with your stroke physician. I am a little bit alarmed sometimes because there's some advertisement sort of almost going on for left atrial appendage occlusion. Its kick has come off really strong in America. My brother works in America and he sort of does 25 of these a day. It's very profit driven. And so we have to be a little bit careful because the evidence really isn't that great. They've used bridging therapy and there are complications. I'd really caution you and make that referral decision in collaboration with a stroke physician. It's really a multidisciplinary team decision, including a cardiologist, a neurologist, and a GP, I think, I would say, and the patient.
Interesting question here from Robert about LDL versus total cholesterol to HDL ratio. And I think my take on that is that the ratio measures risk, but the target of treatment is to LDL. It's a bit of a contradiction.
Yeah, no, I agree with you, that, Bruce. That's sort of a confusing thing. That's why I personally think the LDL is the one to think about, because that's the one you treat and that's the one you're trying to get lower. And HDL, it's very interesting that, even though we know that HDL is protective, there's been there are a large number of trials which raise HDL cholesterol but have not lowered risk. So we know that the thing we need to treat is the LDL. So why don't we just focus on that and getting it down? Now having said that, the total to HDL ratio is a slightly better predictor of cardiovascular risk than the LDL. And so that's why it's used in those risk equations. So it depends on whether your thinking is kind of treatment focused, which should be the LDL, or risk focused, in which case it's the ratio.
A good primary care question here. So we go for targets of less than 1.8 for LDL after an event, but if we start treating for primary prevention, should we do the same? I mean, it always seems to me a bit odd that we don't have a target for primary prevention, but we do for secondary prevention. And I wonder if we're under treating people sometimes.
It's the same thing with why don't we put everyone over the age of 60 on an aspirin, right? So we just don't have the evidence that it makes a population level difference. And at the same time, we are appreciating that we should probably treat lower risk people earlier to prevent risk. So I think it's a bit of a void of evidence, because the studies have been done in the really high risk patients. So we're just slowly gaining an awareness, this common sense. You're saying, well, why wouldn't we treat it when people don't have risks? But the few studies, certainly around antiplatelets we've had, just hasn't shown the benefit. And I think that probably the reason is because if you yes, having a high ADL is certainly a risk, but having had a stroke, your risk really goes up a lot, because now you've declared yourself as a high risk person. And certainly when you're talking about antiplatelets, you can have bleeding complications, right? So the risk, it's not necessarily that that it's not helpful, but the risk benefit ratio, I think, shifts. And that's where I think that's the issue. But I just don't think we have evidence to support that quite yet.
I mean, given the absence of evidence, I think perhaps we could say to patients, well, if you take a higher dose, you possibly will get more benefit, but you know, we don't know that yet.
I certainly think in a similar line of thinking, really. I mean, I think if you've got somebody who's actually got the disease and has a consequence of the disease, then you're treating the disease, and that there's a certain framework that goes around there. And my view is, you know, you need to treat that as best you can with the tools you have and the medication you have, that assuming they're well tolerated. And it's a somewhat different thing where you say, well, we're treating somebody to stop them getting the disease, which they may or may not get, and the probability is X or Y. That's a different sort of thinking process in my one, and I agree, it's just much harder, and obviously, you know, identifying what the risks are and individual judgment make more sense, and I think probably more moderate approaches are probably, you know, which also reduce the risk, but maybe not as less, but don't require as much close monitoring or side effects or those sorts of things, is probably reasonable.
Yep. Emma Smith has put in the Leicester protocol for CVD risk and antipsychotics. So that's good to see. I'll take off. Now we're just about running out of time here, but just wonder if you two could just say, what's the one thing you would wish that we do in primary care that would make a difference? Because I understand we don't do too well on the international stroke comparisons. Other country, for a developed country where when I look at Valerie Fagan's data, we're sort of not in the group where we would like to be. So what's your take-home message for us that we will sleep on it tonight?
I think the most money is in atrial fibrillation. I think that I think it's underdetected and undertreated. And
Yep.
I think that if we could all make a big effort on that front, it would go a long way.
So maybe screening more older people for atrial fibrillation.
And being a little less reluctant about treating people who've had a fall or who've had some frailty. And if you're uncertain, consider trying the tool or consider calling a friendly specialist at the hospital to have a conversation.
Yeah. Rafe, what's your message for the audience?
Well, I think Anna's message is a very good one. I think that one of the challenges you have is that there's so much work and there's so many patients. I think that the patients who actually have the disease, keeping them on the treatments that we know over time reduce their risk of adverse outcomes. Is a huge thing, and we know it's a challenge because the treatments don't generally make people feel better one day to the next, and there's always the question of whether they might be causing some adverse effect over time. But we're really struck by how many, you know, if somebody's had a heart attack or heart failure and they're on medications which we know over time should, at least in theory, reduce their risk by between 60 and 70%. That if they and then within a year, 60% of people are off their medications, and we're wondering why. And and obviously there are good reasons. So that's the real challenge. So engaging people in the need for these treatments, which have been, you know, really have powerful effects when added together and combined in high risk people over time, they may really make a difference. And you know, we're believing that and encouraging patients to believe that, and then it's a negotiation, obviously, but I think we could do a lot better there than
Well, in
the young
terms of effect sizes in primary care, treating atrial fibrillation has one of the biggest effect sizes. So I sometimes do it the other way. If you're on a desert island, what's the last one you'd stop if if you wanted
Yeah.
to stop your medication?
But I mean, I think the discussion about stopping medication, it's got to be, why would you stop medication? It's going to reduce the risk of your bad outcome. I mean,
Absolutely,
I mean, I think you've got to, it's a matter of discussing why, simplifying regimes. I mean, a lot of regimes can be once daily. And, obviously we have to be very aware of side effects and adjusting the treatments accordingly. But if you take, it's probably the simplest thing you can do if you've got vascular disease is take a few tablets and get on with your life. And, and persuading people that actually is a worthwhile thing.
Great. Okay. Well, thank you very much. So two experienced and popular presenters. So thank you very much for contributing to the Goodfellow tonight. I think that was a fantastic session, covered a lot of ground. Didn't get through all the questions, but I think we got through most of the key ones. So, so thank you very much to the audience and to our speakers.
Thanks
And
for
good
having
night,
us.
everybody.
Thank you.